Part of my job here at Mercy is to go directly into the rooms with the patients, primarily from primary care referral. And a lot of our patients do have different mental health issues, and what I can help them do is link with mental health counseling. It's been really great that we have Spectrum here right in the building, because they can do the intake right on site and they can start here with Michelle where they feel comfortable coming to Mercy instead of going to like a strange building, and we can get them engaged right here all at once.
I find it a good program because it's helpful to the primary medical doctors. Often they think there might be an issue with chemical dependency, mental health, they might be a high-risk client, and I have gone into the office and assessed them for lethality. We have different programs that we could get them involved with right away if it's necessary. So I work with the client, I de-escalate the situation, and I sign them up for an assessment to be done.
We have social workers, we have mental health services. We actually have partnership with Spectrum, so we have a counselor on site. So with DSRIP, we are able to, once these patients, the first entry to the healthcare system is the ER. And if you discharge them and hand them a handout, say follow up and call a primary care provider, it never happens. Especially patients that really don't need to see a psychiatrist right away, and I can treat. They can get the counseling part of it. And at the end, I think most of these people are living better and they look like being more productive in the community.
Looking at how to provide medicine to a population of individuals at an efficient cost is exactly what population health does. And so having tools and strategies that address that is exactly what is needed in order to survive in a value-based model.
All those EMRs, sometimes they talk to each other, sometimes not. So as an integrated enterprise system, how we can leverage all the data sources to make it work for the patient population is that we have an enterprise data warehouse that collects information from all those EMRs. Then we can run analytics and do data tabulation on these data sources and try to figure out what's the best for the patient, what are their needs. They need to know that the data we get to them are accurate and relevant.
One of the things that is unique about our process is that we have monthly meetings where all of the 6 practices are asked to come together. From each practice, we have a clinical and an administrative lead. So we do request that both individuals be present at each of these meetings. When they come to the meetings are available so that everybody can have shared learnings related to their work on the case. So then the question is, what happens in between that time? This is when they meet with their individual clinical transformation specialists, and during those individual meetings is when they break down the quote-unquote homework that they are provided from the previous meeting. So that's the type of work that allows for them to get right into the tool, start being able to see who these patients are. Of course, that brings up additional questions because now they're comparing that to what they already know or what they think they know about their current patients. And then based upon the way their homework turns out, everybody comes together. So it works out really, really nice, and we do that monthly.
DSRIP funding supports a lot of initiatives we are doing here. For example, the community health workers, their work is supported by DSRIP fund.
The CHW program is a successful model because the workers themselves are of and from that community, so they understand the need and the culture of that community. They are able to bridge gaps, not only for medical reasons, but other resources, other barriers that the patient may be experiencing.
So I met Yasmin at Mercy OB. She missed an appointment, and when patients miss an appointment, that sends a flag to me, and I met with her in one of the patient rooms, and I introduced myself as a community health worker, just trying to see, what barriers she had getting to her appointments.
Well, when she first came to me during my pregnancy, I was going through a lot of stuff. So I was in the process of moving, I was in the process of about to give birth, and then she came to me and I heard about the Buffalo Urban League. So I figured, any help is all help. So I figured I'll go to her because, this is a place that I've heard about in the past that can help people with housing or with babysitting or anything. So when she offered her services, I immediately accepted because I was already going through stuff at the time.
So the Buffalo Urban League is a non-for-profit organization, was established 92 years ago. So we're of and from this community. It established a partnership with Catholic Medical Partners and Catholic Health to service the community that we are in, to service our own individuals.
Our job every day is to take care of our patients, to help with their compliancy and their daily vital signs of blood pressures and heart rates, all in a means to help prevent a rehospitalization of congestive heart failure or hypertension or AFib, whatever their diagnosis might be.
It's a collaboration with Macaulay-Seton, Catholic Health, and Home Connections. And it affords us funding and an opportunity to check in on our patients every day and make sure that they're doing well, they're taking their medications as prescribed, and this collaboration has been great to help keep patients safe and home and not at the hospital.
And there are not a lot of programs out there for the palliative care program. We get our referrals from Home Connections. There's another organization within Macaulay-Seton that we get some referrals from on patients who might be suitable for the palliative care program. And once we receive their name, we get a doctor's order to put the telemonitor in for their daily vital signs of blood pressure, heart rate, and oxygenation. Then an install is scheduled. We go out to the patient's home and we put a tablet like this in the home for a patient. It also comes with a blood pressure cuff, a pulse ox, and a scale. And daily, they're instructed on how to use this. So this is what the tablet looks like. It alerts them in the morning if they've forgotten to take their weight. It comes over verbally, gives them a little reminder. So then they come and they get their blood pressure, their vital signs, their weight, and then there's a little section for how are you doing today? And it asks questions like shortness of breath or a rapid heartbeat or a cough, things that help us with our nursing assessment that numbers don't always tell the full story.
A very important piece is the relationships that we establish with our patients and how we get to know them and they get to know us and trust us. And you can't put a medical tag on that. That's trust and faith in us. We've seen readmissions reduced, we've seen hospitalizations reduced, and ER visits reduced. So it's a good thing. I hope it'll stay in place.